Hey guys, welcome back to me talking about kind of whatever I want relating to step 3 in a pretty disorganized manner, but I hope some people find this useful because we're jumping from topic to topic, just kind of how the test does. Let's start off today with a little bit interesting topic, euthyroid 6 syndrome. Now, I got a question on this, and basically they gave you all the thyroid labs, and everything was kind of normal. But weirdly, they give you reverse T3 in the labs, and you're thinking, what? Why would they give me that? That's so uncommonly tested, reverse T3. And they also gave you T3 as well as T4. So now, in a regular thyroid panel, I know most places usually just test T4. T3 is really uncommonly tested. But in this case, you're going to have, so T3 is actually the active form of thyroid hormone. In this case, you're going to have a reduced conversion of T4 to T3. That's what euthyroid 6 syndrome means. And it's euthyroid because the TSH and the T4 will be normal, just the T3 levels will be low and the RT3 levels will be high. And in this case, they give you this and they essentially tell you, oh, the person's in the hospital, they're there for some kind of chronic illness. Most commonly, this happens with severe physical distress. So they've had an exacerbation of some kind, and really how you revert this back to normal thyroid hormone levels is to treat the underlying condition and it'll improve. So you don't replete thyroid hormone in this case, and that's a common, that's where they'll try to trick you. Don't replete the thyroid hormone, just treat the underlying condition. Speaking of kind of sick syndromes, another sick syndrome is sick sinus syndrome. So sick sinus syndrome is, or triple S, is basically a dysfunction of the SA node where it becomes fibrosed, and this happens generally with age, and then you get arrhythmias as a result of the sinus node not functioning properly. So with this degeneration, you have things like bradycardia at some point in time and tachycardia at some points in time. So you have an alternating bradycardia tachycardia pattern. This is very classic. It's called tachycardia bradycardia syndrome, as the name implies. It's very descriptive. So in this condition, you'll have your heart rate going all over the place. In an elderly person, basically you can diagnose this with either an exercise stress test or an atropine challenge, and you'll see that the person has something called chronotropic incompetence. So their heart rate will inadequately go up during a stress test or an atropine challenge. And that's how this is classically tested on an exam, where you have someone who's an elderly person, they have bradycardia tachycardia syndrome, and then their exercise stress test is non-responsive. In asymptomatic patients, you don't treat this at all, but for long-term therapy, most of these patients will require a pacemaker. Okay, what's another interesting topic that I think is kind of high yield? Okay, let's talk about congenital adrenal hyperplasia. So basically, this is a group of autosomal recessive disorders for enzymes responsible for the production of your adrenal gland hormones, and this includes aldosterone, cortisol, and very rarely also androgens. So there's 3 enzymes here that we have to know about: 21, 11, and 17. And if you can, pull up a little box chart of how these interact with one another. So if you pull up a box chart, you'll see that pregnenolone will be in one of the corners, and that will be converted into the end hormones of either aldosterone, cortisol, or estradiol, depending on which layer of the adrenal you're in. So if you're in the glomerulosa, you're producing aldosterone; the fasciculata, you're making cortisol; and the reticularis, you're making your estradiol or your androgens. And what you need to know here is a couple key facts about how these symptoms present. Now, 21 beta hydroxylase deficiency is going to be the most common, so it's probably also going to be the most tested. And the way you differentiate between these disorders is you look at what they produce, and you look at the main symptoms of those hormones. So if we're looking at 21 beta hydroxylase deficiency versus 11 versus 17, that one is unique because in 21 beta hydroxylase, it's the only one where you have hypotension. Now, people don't really look at the blood pressure in these kinds of questions. They're too busy looking at the genital deformities or the sodium imbalance. But look at the blood pressure. Trust me, it's going to be a big hint as to which one of these it is, because 21 beta hydroxylase is the only one of these three deficiencies that has hypotension. Now, why is that? Well, it's because it's the only one that doesn't have an increase in deoxycorticosterone, which has mineralocorticoid-like activity. Okay, both 11 beta and 17 alpha hydroxylase deficiencies have an increase in deoxycorticosterone. Now, remember in the pathway that 21 comes before 11 beta, right? So it's kind of out of order in that way. So without 21, you're not producing DOC or deoxycorticosterone, and with 11, you're producing an excess because you're stopping right after in the processing of aldosterone. Okay, so you have an increased mineralocorticoid production with 11 beta and 17 alpha, which is going to raise your blood pressure, right? And you'll also, because 21 beta doesn't produce this mineralocorticoid, you're stopping mineralocorticoid production. Because of that, you have derangements in sodium and potassium. Remember, aldosterone is going to absorb sodium and kick out potassium. So in that case, you're going to have high potassium, low sodium. And the other thing to look out for, so the mineralocorticoid, the other thing to look out for is the androgen function. So with 21 and 11 beta, you'll have increased androgen production because now everything is getting shifted down the 17 alpha pathway. And with 17 alpha, you have a decreased androgen production. So two things to look out for: blood pressure and electrolytes, which you can really summarize with blood pressure if they give it to you, and androgens. Okay, so how are these people going to present? We've already talked about the mineralocorticoid effect. Now let's talk about the androgen effect. Okay, so let's say you have a female, we'll do female and male presenting with each. Okay, so an XX female presenting with 21 beta hydroxylase deficiency and 11 beta is going to present the same, right? You're going to have increased androgens in this female. So you have virilization, you'll have irregular menstrual cycles, infertility, clitoromegaly. So you're going to want, the body's trying to form a penis out of that clitoris. Okay, so that's a female presenting with 11 or 21 beta. Now let's say a female is presenting with 17 alpha, right? You'll have normal female external genitalia, your androgens are suppressed, but in this case puberty will be delayed because you need androgens in order to go through puberty. Okay, so that one is the hardest to detect. Then let's say you have a male, okay? A male with 11 beta or 21 beta, both of them have high androgens, right? You're going to have precocious puberty. You're going to have early puberty in this male. And you'll have normal male external genitalia because your androgens are high. You're making a penis anyway. And then let's say you have a 17 alpha deficiency in a male. This male is going to present with pseudohermaphroditism or female external genitalia. Okay, so you'll have a blind ending vagina. You'll have, it's similar, very similar to androgen insensitivity, right? Because instead of being insensitive to androgens, now you just don't have any. All right, so the important thing to remember is that 21 beta is the most common. It's the most tested, and if you have an infant that was born with 21 beta, they will often present in a state of shock because you have very low fluid retention, right? Your aldosterone isn't working, your mineralocorticoids aren't working. So you'll have severe dehydration, acute adrenal crisis, salt wasting, and usually these kids can present in a state of shock. Okay, so that's pretty much the quick review on congenital adrenal hyperplasia, and I hope that summarized it for you. I think the chart is very helpful to look up to understand the pathway if you didn't have it already kind of in your head. Another thing that's, let's talk about another random topic, uremia. Okay, so uremia is basically a renal problem. So uremia and ammonemia, high ammonia levels, high urea levels, they're linked, right? Ammonia gets turned into urea, which then goes out through the renal system. Ammonia is made by the liver. Urea is, ammonia is processed into urea at the liver. So if the liver's not working, your ammonia is going to go up. And if your kidneys are not working, your urea is going to go up, right? So if you have high urea, how does that present in a person? So a person with a long-standing kidney damage, urea can actually cause pruritus, just like bilirubin, hyperbilirubinemia. So you'll have itching. These people can also present with classic uremic pericarditis. So high urea can accumulate in the pericardium and cause inflammation there. And you'll see the classic ECG findings of pericarditis. It can also cause pleuritis. So the pleura, the pericardium, can become irritated. And in these patients, you also want to watch out for one more thing, and that's platelets. So in these people, you'll have decreased platelet function, an increased predisposition for bleeding. You can also have anemia because of the coagulation's not working properly. These platelets can get shredded, accumulate and shred red blood cells. So anemia, bleeding tendency is very common in hyperuremia. Now, if we go to the other spectrum of hyperammonemia, this is a liver problem. So in the liver, ammonia gets converted to urea. There's a bunch of enzymes in the urea cycle that are pretty low yield to know about. But if you want to go all the way back to things like ornithine transcarbamylase, carbamoyl phosphate type 1 and type 2, all of these, if you see any of these mentioned on the test, you know you're dealing with the urea cycle, you know you're dealing with a potentially increased ammonia level. And hyperammonemia can cause things like delirium. It can accumulate in the brain and cause the person to be essentially out of whack. In these cases, you're going to have you can do things like a liver biopsy, or it depends on the cause, because you can have hyperammonemia from things like cirrhosis as well. So they'll give you usually a defining feature, and then I'll let you figure it out from there. And speaking of, genetic or enzyme deficiencies, we can talk about, on top of that, we can talk about inborn errors of metabolism. So these are not super high yield, but they are often the kind of trap questions, because they know people don't really study them as much, and so the test examiners like to go for these topics. One of the main ones here is alpha-1 antitrypsin deficiency. So this is a genetic disorder where the enzyme alpha-1 antitrypsin does no longer stops neutrophil elastase from functioning. So you have an overactivity of neutrophil elastase, and these elastase enzymes basically like to accumulate in the liver and the lungs. And with these enzymes damaging the liver and the lungs, you have hepatocyte destruction, which causes cirrhosis, and you have pan-acinar emphysema in the lungs. So those are the two things you'll see, and you'll see this in someone who's a little bit younger, 35, someone you wouldn't really expect to have this kind of clinical presentation. So sometimes they'll try to trip you up and give you a smoker, but the cirrhosis isn't really consistent with that, okay? And smoking doesn't give you pan-acinar emphysema. And in these cases, you'll have basically a person with hepatitis, cirrhosis, prolonged episodes of jaundice, chronic cough. So liver plus lung, alpha-1 antitrypsin, especially in a young person. Okay, in the liver biopsy, which you can use to kind of diagnose this, you'll see PAS positive inclusion bodies. That's another thing they like to test. And if you have anyone, essentially anyone with emphysema under the age of 50, you can consider this disorder. And regardless of if they smoke or anything else, you can consider this. You can consider that they have the PIZZ mutation. That's the common one tested here. Z is kind of the mutation that causes the most significant alpha-1 antitrypsin deficiency. Okay, so just make sure you watch out for this disorder in the liver, the lungs, in someone under 50. Then we can talk about myocardial myopathies. That's another one that's kind of a error in metabolism because the mitochondria aren't working as they should. In these cases, you have diseases like May-Loss, MRF, Leber hereditary optic neuropathy. So mitochondria, right? They are the powerhouses that kind of create all the energy in the body. And when you have a inborn error in metabolism of mitochondrial function, your oxidative phosphorylation pathway isn't working. So you have lactate accumulating, and the tissues that suffer the most are the ones that require the highest metabolic demand, which are nerve tissue and the brain. So in May-Loss and MRF, you're going to have toxic seizures, and you're going to have optic problems, as well as muscle problems, because mitochondria are also heavily found in muscle. So the nerve tissue and then the muscle tissue are going to be most heavily affected in these mitochondrial deficiencies. And so I don't think it's really high yield enough to be able to differentiate between a May-Loss and a MRF and to know kind of which ones have which features. And you should just know that these are mitochondria are maternally inherited. They're going to affect the brain and the muscle the most, and that those are the high yield points to know there. The other one that might bring you back to step 1 is PKU, or phenylketonuria. And this one is an inborn error of metabolism that involves accumulation of phenylalanine. And this is an autosomal recessive mutation where phenylalanine hydroxylase in the liver does not work anymore. So you have impaired conversion of phenylalanine to tyrosine. So tyrosine becomes the deficiency in these patients, and it becomes essentially it goes from becoming a non-essential amino acid to an essential amino acid. So you have to supplement tyrosine in these kids. Okay. There's really 2 forms that you have to know: the malignant PKU form and the maternal PKU form. The malignant PKU form is caused by tetrahydrobiopterin deficiency, and the maternal PKU form is just the mother's phenylalanine hydroxylase not working. So the tetrahydrobiopterin is a coenzyme in this whole reaction, and it's one that they really like to test because it sounds different. If they give you phenylalanine hydroxylase, you're really likely to go for it in these kinds of questions. These kids are going to have a very classic presentation. They'll have a musty odor because you have an increase in these aromatic amino acids building up in the body. They'll have eczema, they'll have growth restriction, seizures are another common one, intellectual disability. And these are usually screened for. So PKU, the chance of finding out later in the child's development is really low because they do a blood test early on, right after the child is born. They'll do a little heel prick and test for these inborn errors of metabolism, because the earlier you treat them, the better the outcomes for the child. And how do you treat this if you find out, let's say, a little bit later? You definitely want to start on a low phenylalanine diet. and a high tyrosine diet. You kind of want to skip this step. And tetrahydrobiopterin supplementation is also helpful in these cases because you want to supplement the pathway as much as possible if there is some remaining functional enzyme there. And you should also, this concept they really like to test, you should also avoid aspartame because aspartame contains phenylalanine. So you're trying to pump phenylalanine into this pathway, it'll build up in the body, it'll build up in the brain, cause these problems with the growth restriction, it'll cause problems because with the psychomotor delay, with the mental retardation. So phenylalanine, it's a brain destroyer. It's not converted to tyrosine like it should be. And PKU is an inborn error of metabolism that involves tetrahydrobiopterin as a cofactor. Those are the important key points there. Homocystinuria. Homocystinuria is essentially you can't destroy or create homocysteine like it should be. So the enzymes here are either methionine synthase or cysteine synthase or methyl hydrotetrafolate reductase. These are all involved in homocysteine production and destruction. So in methionine synthase, is also known as homocysteine methyltransferase. This, when it's deficient, causes an impaired conversion of homocysteine to methionine. So you have a buildup. Homocystinuria is when you have too much homocysteine and you kind of have to pee it out. Cysteine synthetase is a different pathway where homocysteine builds up because it's not converted into cysteine. So you have two pathways where the accumulation builds up back into homocysteine. I think it's not as high yield to know the pathways, just know kind of the clinical presentations of this condition is more important. So this is a common differential for Marfans because these people will be tall and thin, they'll have scoliosis, they'll have elongated limbs, their joints can be hyperlax, and another important thing to know is that if you're looking at the lens dislocation, homocystinuria has a lens dislocation that is essentially apical, and then Marfans has a lens dislocation that's lower, so the lens dislocation will be towards the floor, and that's kind of how you differentiate based on lens dislocation. Also, you have increased risk of clots in these people. Homocysteine causes clotting all over the body. It also causes atherosclerosis and heart disease. So definitely not a good compound to have building up everywhere. To treat this, you want to give high doses of B6 or pyridoxine. This is going to help this is a cofactor in homocysteine metabolism. So it's definitely going to help throw this homocysteine down other metabolic pathways. And you can also give low methionine diets, which can help a lot, and you can also supplement folate. So folate, especially in MTHFR deficiency, can be helpful, and pyridoxine. So supplementation, avoiding methionine are the main factors here, and the main differential here is lens dislocation. So down for homocystinuria and up for Marfans. I'm sorry, I mixed that up before. So homocystinuria, you look down. Marfans, you look up with the lens dislocation. Okay. Yeah. So those are the main key points there. Remember the lens dislocation, they like to test that. Homocystinuria is low, Marfans is high. Okay, upwards versus downwards. Just remember that key association. The other one we can talk about is Hartnup disease. Hartnup disease is a genetic disorder that's characterized by impaired renal and intestinal transport of neutral amino acids. So in these cases, the kidneys cannot reabsorb amino acids. You're going to have a decrease in one key one in particular called tryptophan. Now, Hartnup disease is a differential, again, remember the differentials here are important. It's a differential for pellagra, because if you can't absorb tryptophan, you can't form niacin or B3. Okay, so these people will develop pellagra. So you'll have dermatitis, glossitis, diarrhea, dementia, and death, the D's of pellagra in these patients. So, and you can also develop high amino acids in the urine. So that's going to be your diagnostic test here. High amino acids in the urine. You want to avoid high protein diets for these people because the amino acids aren't being well shuttled, and you're going to develop more problems with building up of these neutral amino acids. And you also want to supplement with niacin so you avoid pellagra. Next is maple syrupy urine disease. That's another step 1 favorite, but I think it's coming back in step 3 as well. You have in these cases impaired breakdown of branch chain amino acids. This is autosomal recessive. A lot of these are autosomal recessive, so if you had to make a guess on what the inheritance pattern of these diseases are, they're going to be autosomal recessive. You have sweet smelling urine, that's why it's called maple syrup urine disease, with kind of a burnt sugar odor. These people develop intellectual disability because these branched chain amino acids build up in the brain, dystonia, they're affecting the basal ganglia, and you can even get death if the brain is damaged enough. In the serum, you'll have increased of things like alpha keto acids, especially leucine. The common ones here are leucine, isoleucine, and valine. These are those branched chain amino acids, and they can go down the ketosis pathway to form alpha keto acids. Okay, so watch out for that. And you can have also hypoglycemia. I think these keto acids have a negative impact on gluconeogenesis. You guys can correct me if I'm wrong on that one. So you need to avoid in these patients BCAAs. You want to supplement with things like thiamine, which is a cofactor of alpha keto acid dehydrogenase, and that's going to help reduce the alpha keto acids and help metabolize them away. All right, so remember that maple syrup urine disease, just like the maple syrup tree, it's branched chain amino acids, and just like you want a live maple syrup tree, it's LIV, leucine, isoleucine, valine. Next is cystenuria. Cystenuria is, I actually know someone with cystenuria. It's a very rare, 1 in 7,000 autosomal recessive condition where you pee out cysteine and you're going to form these classic hexagonal cysteine stones. And it's a little bit tragic because, you need to be very careful with these children. They form giant renal stones. They form recurrent stones. You need to give them potentially a chelating agent like penicillamine to try to chelate out that cysteine before it can accumulate and form stones. Other things that can accumulate in these people with cystenuria is amino acids like ornithine, arginine, lysine. These are all compounds that can form stones like that, but the main one here to remember is that cysteine forms those hexagonal stones. You want to alkalinize the urine because it forms in acidic environments, and you want adequate hydration in these children. We have pyruvate dehydrogenase deficiency next. Now, pyruvate dehydrogenase is kind of the end point in pyruvate metabolism. It's X-linked recessive, so if you have impaired pyruvate dehydrogenase, you can't form acetyl-CoA from pyruvate, and then you can't go into the citric acid or Krebs cycle, and you have a large energy deficit. So you're essentially now going back to lactic acid to try to produce any form of NADPH and things like that, or NADH, sorry. So you're going to have high lactic acidosis in these kids. It starts off very early in the neonatal period, and you'll have a definite buildup in lactate. So if you have a neonate with high lactic acidosis, you definitely want to consider pyruvate dehydrogenase deficiency, and that's pretty much the high yield point for that. The other thing we can talk about is adenosine deaminase deficiency. We mentioned this already in SCID. It's autosomal recessive. So if you have a buildup in adenosine deaminase, you potentially target your T cells, and now you have immune dysregulation, and you have all the sequelae that come with that in terms of SCID. Now we can keep going on and on to like things like arginase deficiency, ornithine transcarbonylase deficiency, orotic aciduria. There's actually like 1,000,001 of these inborn errors of metabolism. But I think we've covered pretty much the high yield ones. If you want coverage on any of them in specific that we haven't talked about already, you can post a comment down below and we'll get to it in the next one. But I really want to move on because I want to talk about a really cool topic, and I think it's also pretty high yield on the boards, which is toxicities. So toxicities is things like cyanide poisoning, things like mushroom poisoning, carbon monoxide, carbon dioxide poisoning, ethylene glycol, things like that. And these are interesting, but also high yield. So I think the most tested one that I've seen is organophosphates. So organophosphates are nerve agents. They're sarin gas. So if you ever see a question with a terrorist attack, they're most likely talking about organophosphates. What they do is they inhibit acetylcholinesterase. So you have a really high buildup of acetylcholine, and then your muscarinics go out of whack and they go crazy. So you enter into a cholinergic crisis, and you get what you kind of expect with a cholinergic crisis, a parasympathetic crisis. You get bradycardia, hypotension, diarrhea, vomiting, sweating, salivation. There's a mnemonic for this called sludge, where each of them is a different parasympathetic symptom. But the key ones to remember are the excretory ones from the GI tract. The bronchospasm is another key high yield one. So if you have a muscarinic agonist overload, you have bronchospasm going on. And then how do you manage this? Well, you have to get them away from the source, obviously. You can give atropine acutely. So a muscarinic antagonist in the acute phase is very important. And then in the longer phase, you can give pralidoxime, which is going to help to unbind this acetylcholinesterase inhibitor from the organophosphate, or from the acetylcholinesterase. Okay, so that's pretty much it. And these people, the way they die is really from respiratory failure, from the bronchospasm and excess secretions. That's the highest yield point there. So remember the lung findings with organophosphate poisoning. Next is cyanide. So cyanide is poisoning that's commonly found in household fires. You can also get it with sodium nitroprusside if you're treating something like a hypertension, or if you're giving someone with hypertension who has renal failure nitroprusside, you're setting yourself up for cyanide poisoning. And what happens is, in these cases, you're having a high buildup of CN, or cyanide, which can't be appropriately metabolized. And the way cyanide works is, if you remember back to step 1, it latches on to complex 4 of the electron transport chain, and essentially your oxidative phosphorylation goes to doo-doo, and you got no aerobic metabolism anymore. These people are going to smell like bitter almonds. They're going to have vertigo, headache, nausea, vomiting, really kind of unspecific signs. But some of the key ones is that you'll see high anion gap acidosis in their ABG. So you'll have a high buildup of lactate because your electron transport chain is not working, right? And then bright red retinal veins on their fundoscopic exam is another one that I've seen tested. And they'll present usually with dyspnea, arrhythmia, some kind of confusion, agitation, syndrome, and you have to kind of tease out the source and the exposure, right? So the one thing that you also should remember is that you'll do a pulse ox on these people because fires, you also don't want to confuse that with carbon monoxide, and it's going to be initially normal. Pulse ox on a carbon monoxide patient will also be initially normal, so it doesn't tell you much. Carbon dioxide, though, you'll have a potentially decreased pulse ox. How do you treat cyanide? So there's 3 drugs that are good to remember. Hydroxycobalamin, which is a basically precursor to B12. It binds cyanide and forms cyanocobalamin, which then can get peed out in the urine. This is first line. So hydroxycobalamin, if you see that on the test, just go for it. But sometimes they like to test the older solutions, which is sodium nitrite and sodium thiosulfate. So sodium nitrite, what it does is it acts it poisons you to help you. So it creates methemoglobin. And if you have methemoglobin, it's going to like to bind cyanide, which forms cyanomethemoglobin, and then that cyanomethemoglobin takes it away from complex 4 and essentially allows you to do oxidative phosphorylation again. And then you have sodium thiosulfate, which basically gives a boost to rhodinase. Rhodinase is an enzyme that detoxifies cyanide into thiocyanate, and then you can pee it out with urine. So usually you'll give sodium nitrite and sodium thiosulfate kind of in a sequence so that you can have both of them acting together. Hydroxycobalamin can sometimes be given independently. So if a person has methemoglobinemia already, right, they might try to trick you with this. Someone who comes in with methemoglobinemia, you might make them worse by giving them, sodium nitrite or amyl nitrite. They're essentially, they work in the same way. So don't give that in those cases. They'll try to put a contraindication where they'll lean you towards hydroxycobalamin instead. Okay, and you always want to consider this poisoning in someone with renal failure who's been in a recent hypertensive emergency. So that's a very classic vignette for cyanide poisoning. Renal failure, hypertensive emergency. They'll emphasize it. Next, we'll talk about ethylene glycol. So this is everyone's classic antifreeze question. If you ingest ethylene glycol, people eat it, or animals eat it, or kids eat it because it's sweet smelling, and you're going to essentially get 2 things: altered mental status and calcium oxalate depositions, and it's usually going to be in the kidneys, and you're usually going to get crystals and stones. So watch out for that. Ethylene glycol works kind of works as an ethanol substitute, so it works down the same pathway. Some people with alcohol use disorders can sometimes take ethylene glycol because they read about it on forums and stuff. So it's your classic antifreeze question. And you're going to have high osmolar gap in these people. You're going to treat it essentially the same way as isopropyl alcohol or methanol. You want to give something to bind the alcohol dehydrogenase pathway and prevent its metabolism further down the line. Okay, so that's ethylene glycol, methanol, isopropyl alcohol. The general approach for all of these is that you're going to use either fomepizole, which is first line, or ethanol, which is second line, to competitively inhibit these from binding with alcohol dehydrogenase and getting processed further down the line. So, methanol creates also a high anion gap metabolic acidosis, and isopropyl alcohol does as well. It's metabolized to acetone, so you're going to have increased serum ketones in that case, and in all of them you could have some fruity smelling breath from the ketosis. So essentially you can throw them all into one bucket and say, in these patients, you have high anion gap metabolic acidosis. You can do hemodialysis for very severe cases, and fomepizole is your main thing to consider. Okay, so these people, the prognosis isn't great, especially for methanol. You know, if you have like 15 cubic centimeters cc's of methanol, you can already induce blindness in some cases. So watch out for these people. They're usually alcohol abusers. They'll have a history of alcohol abuse, and they'll present to the ED with this kind of acidotic picture. Next, we can talk about things like detergents, mushrooms, plants. What should we talk about? We should talk about, let's talk about mushrooms. So mushrooms, essentially the only thing you need to know for detergents is that you don't want to induce vomiting or any kind of like detergent or gas or one of those things that can corrode the esophagus. You don't want to cause vomiting because you're just going to bring it back up and cause a second layer of damage. The things you need to know about mushrooms. So the mushrooms here to know, the main one is Amanita phalloides, or the death cap. This one is a pretty interesting mushroom because it causes two layers of symptoms. The first one is within 24 hours, where you have GI symptoms, diarrhea, vomiting, and the second one is within 4 days, where you have renal and liver damage, and essentially that's when it kills you. So Amanita phalloides creates alpha-amanitin, which blocks RNA polymerase. And if you have a blockage of RNA polymerase, there goes your mRNA, and eventually, you know, you'll get apoptosis. So the main organ it's going to affect is the GI tract, because that's where it comes into contact with your cells first, right? That's where it gets absorbed, and then eventually it'll flow its way up to the liver to get detoxified, like everything from the GI tract, and that's where it's going to cause your liver damage and then eventually your kidney damage after that. So in severe cases, you'll definitely need a liver transplant because you won't be able to, you won't have a functioning liver. Then we can talk about Atropa belladonna. This one is the plant that was used originally to make atropine. So this is also called nightshade. And the antidote for this, so if you have a muscarinic antagonist, you want to treat it by increasing your muscarinic load. So you can give something like a physostigmine to block acetylcholinesterase. Now you have more acetylcholine, now more muscarinic stimulation, and these people are going to be, you're going to downregulate the high sympathetic load that you've just caused by inhibiting the muscarinics. So atropine is going to inhibit your muscarinics. You're going to have the classic mnemonic, blind as a bat, hot as hell, red as a beet kind of presentation, dry as a bone, things like that. So if you just think about it logically, you can reverse the muscarinic by giving physostigmine, which increases acetylcholine. Just like we talked about with the organophosphates, if you boost acetylcholine, you're going to have those sludge symptoms. So you're trying to balance it out in this case. All right, and then lastly, I think we can talk about carbon dioxide poisoning. So this will happen usually with people who are doing indoor fermentation. They're exposed to grain silos, wells, other kind of cesspools of stuff like animal processing, where you have a lot of CO2 production surrounding you, especially in a closed area. And the atmospheric concentration of CO2 right now, while it's going up with global warming, is less than 0.3%, right? So if you have an increase in CO2 exposure, you can get all sorts of health effects. So it can affect your hearing, it can affect your level of consciousness, because CO2 can cause O2 disturbances as well, right? So you want to definitely provide oxygen to these patients to kind of push out the CO2, And in some cases, you can do MRIs and you'll see parts of the brain that are affected by things like carbon monoxide, carbon dioxide poisoning, if it's severe enough. Okay. All right, so I think we've gone through a bunch of different of the poisoning classes that I wanted to go through. Lastly, we can talk about, actually we'll save multiple sclerosis for next time. So we'll cut it short today. And hopefully this was helpful. Hopefully this was a quick review on some of the higher yield topics. I know the inborn errors of metabolism are kind of crazy and difficult to remember all in one shot. Even, I have a lot of trouble remembering them as well. So we can go through that one more time in a later podcast. If anyone decides to comment on this one, we can do it one more time. And hopefully this was helpful, and I'll see you guys in the next one.